Large language models have caught the public imagination because it's the first time that AI has behaved like people think AI should behave. Large language models are incredibly useful if you find the right tasks for them. I'm not a developer, but I was able to do something very, very powerful that's potentially positive and negative and just get it out there. And that's when I thought, now I really need to understand this, and spent a lot of time understanding how the models work and prompt engineering, and then thought, well, what I need to do is tell other people working in healthcare how to experiment with it so they can at least understand this technology and be active participants in the development as opposed to passive recipients of it and lose control. So they can go away and safely experiment with themselves, and they're closest to the problems in the real world. They can start thinking about how this will work.
Hey everybody, welcome to another episode of the Healthtech Podcast. Today, I have got with me Dr. Keith Grimes. Delighted to have you, Keith. Absolutely shocking that you've not been on the podcast thus far with the amount of years that we've been going to the same events, having existential chats about AI and all the rest of it. So, as I say, absolutely delighted to have you on, mate. Welcome. How are you?
Yeah, no, good. I am very well this morning, and I'm equally delighted to be coming and speaking to you today. And you're right, God, we've had some really deep discussions, haven't we, at the different events that we've been to and so on. And so maybe we were waiting for the right moment to have the audience properly prepared for,
Absolutely,
for the depths that we're going to be going to today.
Absolutely.
But no, I've enjoyed your podcast and everyone's work for a while. It's good to be here.
Oh, thanks, mate. Yeah, we're planning to go quite deep, aren't we? We're going to talk about you and your background, obviously. We're going to talk about what you're up to with Curistica, and we're going to talk deeply about thoughts on large language models and where we're going in healthcare with it. So, yeah, without further ado, man, obviously I know your story relatively well, but I guess for the benefit of our listeners, yeah, give us the long version.
Yeah, I'm sure. So, to go back to the right way, hello, my name is Keith, and I am a doctor. Yeah, so the very basics of, and the bit that my parents would be most interested in is that, yes, I am actually a doctor. I've been a doctor for 27 years, a GP for 23 of them, and I still do some clinical practice, although the thick end of the work that I do now is in health tech, digital health innovation. I've always loved technology. Like literally my earliest memory is sitting in a nappy watching Thunderbirds on TV and marveling at the technology. That's that's my earliest memory. I can't remember, 3 or something like that. Should I have been wearing a nappy? I don't know. Either way, Thunderbirds was involved. And I've loved technology all the way along. And I've been fortunate, in my life. I was sort of born in the early 70s. And so I've seen a lot of the great sort of technologies come along, particularly video games was my first great love. I had a Atari 2600. I had a ZX81 Spectrum, then a Commodore 64 forever for those people out there, and just dived into technologies through the 80s and the very earliest internet through bulletin boards and so on, and was a real geek with that sort of thing. It was my very happy place. And as I approached the end of school and was thinking about going to university, I was very, very keen to do computer science or computer games specifically. Now, I come from a family of teachers and engineers. There's no medics in the family, but there was a sense that I was doing really well at school and I shouldn't be doing something as stupid as playing computer games. I should be doing something more. And I was, said, you should try doing either law or medicine. And I was like, well, there's no way I'm going to want to be a lawyer. But medicine appealed to me. I'm the eldest of 6 boys. I've got 5 younger brothers, and there's something about sort of caring for folk and that appealed to me. And so I sort of threw in behind that. And I was back up in Scotland at the time. I went to Aberdeen University. So this is from 1990 to 1996, and enjoyed medical school, enjoyed the study, but was always trying to find a way to bring technology into it. And in the early 90s. It was the dawn of sort of cyberpunk and VR and rave culture. And the combination of all those things really affected me. And so I sort of hung out a lot in clubs, got really involved in the kind of, what do they call it? It was sort of post-human sort of movement and all that kind of stuff. So I was really interested in the use of virtual reality. And actually a lot of the things that we talk about now, the sort of theory and the philosophy of technology, is very similar now to what it was then, but just the technology was really sort of crappy. so I wasn't able to get things off the ground, but I was desperately trying to get technology into healthcare. And so I had an intercalated degree. So I studied chaos theory. And the reason I did the chaos theory is it allowed me the opportunity to do coding. And I studied deterministic chaos and child heart rate variability. I was looking at how measures of deterministic chaos changed in neonates and preterm infants. The idea being is that more complex systems are more healthy systems, therefore more chaotic, and was able to show that, very early preterm infants had low measures of entropy and chaos in their heart rate variability. And as they got healthier and older, that increased. And so I was very much interested in data at that point, but then got dropped back into medicine again and was like, well, technology is just like, printing out lab reports and everything. And then went into my junior house officer years, which was back in the good old days of like 120-hour weeks and so on. And I had an opportunity to use tech there, printing out lab forms and everything. But everyone was like, well, if you like technology, you should probably do radiology. I think they use computers and or anesthetics because they seem to use maths a lot. I know it's very, very sort of basic stuff. But the medicine that I liked was generalist. So I thought, well, emergency medicine would be really good. But while I was working in A&E up in Inverness, there was a GP that came in and did sort of support when we were doing the training on an afternoon. I was just about to head out to Australia for a year. And he said, well, accident emergency is all fine, but if you really want to sort of see the breadth of humanity and really be free to do stuff, you should try general practice. At least give it a go when you get back from Australia. So I did the year in Australia and did a bit of everything and, a bit of veterinary medicine along the way because I was in the bush. And then came back. And back then your GP training, you could kind of roll your own GP training. And so I'd done enough house officer jobs. And then in Australia, I'd done enough sort of variation of work to mean that all I had to do was one more year as a GP registrar, which I did. And that was the first year that I really got into technology and healthcare because it was around about 2000. I was in Edinburgh and I did the practice website. It was all, it was all in text editors and started writing algorithms to help support me in my practice using JavaScript. So it was things like peak flow prediction and pregnancy calculators and stuff like that. And started using my Palm Pilot for medical references. So I started to use technology a lot in my practice, but still was saying, well, this is great. I want to sort of circulate it to other people. But once again, they were like, well, tech at that point was just like networks. And I got to work in Scotland on something called the ECCI program, ECCI, Electronic Clinical Communications Implementation. And that was back in 2002 to 2005. And Scotland's effort to do electronic referrals, electronic discharges, outpatient booking, lab results. I think there was, an email, just like email comms for clinical opinions. So this is actually, still people are still trying to get this done right. And it was all done using macros in Office. But we managed to get it up and running. And it was quite effective, particularly getting the lab results back. And it was the seed of what became the Sky Store, which then became the Urgent Care Summary in Scotland. So that was actually quite successful, but slow going. And up to 2005, I was involved in that. And then we moved down to England, and we moved to England. At the time, I was like, why am I going to go to England? England's a terrible place. But my wife's an opera singer and got a job at Glyndebourne. And we thought, well, we'll go down south and we'll hold our nose a bit and it'll be all right. And we've been here ever since because England's lovely, particularly where I live in East Sussex. And
Nice.
So at that point, came down south. I was still working as a GP with an interest in urgent care and worked in the out of hours sector. So I was doing a lot of night shifts, and that was great general practice. But I was still trying to get into technology and healthcare, and I started a degree in healthcare informatics because at that point, technology meant like healthcare informatics. Mm. So I completed that, and I was working again, trying to get technology in everything that I did. And at the company that I worked for, which was an out of hours provider, they said, well, we can do some technology stuff as long as you also do the clinical governance. And I was like, yeah, let me at the technology. I'll do the clinical governance. And it was all clinical governance, obviously. I was involved in that. So that's where I got a lot of my experience in, quality improvement, complaints, supporting doctors that are struggling and things like that. And actually really enjoyed that. But within that, started to get into clinical safety and became a clinical safety officer for the company as it developed its in-house EHR and integrations with the spine. So I'm getting closer to technology at this point, but still it's moving very slowly. It's kind of that glacial pace within the NHS. It's still seen as a sort of side thing. And I started to try and get involved. The company also worked on technologically enabled care services, sort of care home, remote sensing and the like. So that's where I got my experience of working with wearables back in the early 2010s. And we did a few trips out to Scandinavia where they've got some really good examples of that and saw the benefits that remote monitoring could do. It's still not embedded to the degree that you'd think it was. I mean, everything moves way slower than you think. But that's when I got my first introduction to product. And in fact, as a side product of all of that, I got to work on, this is my first sort of radical problem solution, is that we were working, even though we're based in England, we were working with a Digital Health and Care Institute in Scotland. And one of the problems that they had was parents of children in neonatal intensive care weren't able to see their children because the children were very sick and the parents were often quite sick themselves. And so they were being separated. And the thing was, well, is there any way that we can allow parents to see their child? Using webcams? That was the idea. And what was nice is I was working with a team, a company that's now called Clio Systems, with David Brown, and who's still doing fantastic work. And we rapidly prototyped a solution using off-the-shelf ingredients like a webcam, GoPro housing, and iPads, and built a solution that allowed you to essentially put a camera on an incubator and then securely stream it to an iPad. Now, I don't know what the current state of that is right now, but at that point, no one else was doing it. And we managed to get it up and running and launched in Kirkcaldy, which is just north of Edinburgh. And it was a real success. Now, it didn't turn into a commercial success like a lot of these things. It was solving a real world problem and people loved it, but we hadn't quite worked out the detail of making the money of it. And that's always quite hard in the NHS. But it won a bunch of awards. And there was some research that showed that it helped with attachment for parents and everything. But for me, the thing that really cemented the importance of technology increasing humanity was the day that we launched it. And we had the press there, and a young mum, she was 16-year-old. She had a very premature infant. And, we said, you'll be able to use this device. And, she was happy enough about that. We gave her the tablet. She had the photos taken with her baby in the incubator. And then she went up to her room. And she was up there, and they were like, oh, crikey, we forgot to give her something. So, Keith, you go upstairs and give it to her. So I went upstairs to give it to her. And just as I was outside her room, I looked through the window. And through the window, I saw her on the bed. And she was sitting at one end of the bed with the father of the child, just sitting quietly watching the iPad propped up at the end of the bed and just watching and, looking quite content. And I remember thinking at that point, that is incredible, like something that is just so simple. Of course, it's complexity gives that benefit, something that she would otherwise not be able to get. And at that point, that's me hooked. Find problems, solve them. I don't care how you do it. Let's get out there and do it. And that has been essentially the tale of my career afterwards. Now, you asked for the long version, so I'm diving into it a wee bit deep. While that didn't sort of go anyway, I was back in normal general practice and struggling. I built a wiki for my practice. I was building lots of things to assist me in what I did, and even became the local IT lead, the innovation lead with the CCG here in East Sussex. But at that point, I kind of got hooked on the idea of problem solving. And I went out. I made the great, accidental mistake of going out to some events in the US. The West Coast of the US, particularly. And I went to something called Exponential Medicine back in 2014. And my mind was fully blown because this was like, Ray Kurzweil appearing by robot, Craig Venter talking about sequencing organisms on Mars and 3D printing vaccines, like proper Kool-Aid drinking, West Coast, full of beans stuff. And I was like, this is amazing. But also, I got to meet a lot of Americans. And what I love about America and Americans is that in the UK, I'd say, I've had this idea, I want to do this. And people are like, sounds hard. I don't know if you'll do that. You know how hard the NHS is to work with. But in the US, you'd get about halfway through your story and the person's like, sold. I know someone who can fund this. We're near Sandgate Drive. Why don't we go and meet so-and-so? And you know what? that positivity became like a kind of vitamin shot for the soul. And I started going back to the US and was like, well, these people are getting things done, even in the face of great challenge. And what that led to is me being a bit more, assertive. And two things came out of that. The first of which was me starting to use VR. Now I'm a gamer, and VR, I fell in love with it in the early 90s. It was kind of rubbish. But then it re-emerged in the early 2010s with things like Samsung Gear VR. And so I had the kit and Oculus Rift. And I'd read a lot of the research about how it could be used in healthcare too. But I was very frustrated about how anytime I asked to be able to do something was told no. And I had, in the walk-in center that I was working in, I ran a walk-in center in Eastbourne. So I had my own patients. And one day I had my VR headset in front of me. And the nurse came down and said, oh, can you see this lady? She's just had a baby. She's had an operation which requires wound packing. Every day, every couple of days. And she's breastfeeding, so she's not really keen on taking any pain relief. The packing is very, very painful, and she's having to come down quite a lot. And so can you do something? This is a general practice. I can't sedate her or anything. But she came down to speak to me, and we're talking about things. And she was oddly enough a performance artist. And I'd been watching Cirque du Soleil and 360 video on the headset. And I thought, well, I've got this headset, and the evidence suggests that in burns patients, VR can be really helpful. And you're having a wound packing, so you want to give it a go. And between me and the patient, we discussed it and said, it's likely to be low risk. I've got the headset. I'll be with you, and we'll give it a try. And she was like, yeah, I'll do this. Crucially, I didn't ask anyone else's permission other than negotiation with the patient. Went back upstairs, put the headset on, put on Cirque du Soleil, and then watched this 10 minutes of this woman having a wound packed, and she was laughing and cooing at what she was seeing. And the nurse was like flabbergasted and was able to complete it all, even to the point that we completed the wound care and we had to let the woman know that we'd finished.
And to be clear, distracted from the pain, right?
Absolutely distracted from the pain. And, again, I was like, look at this technology that is right here, right now, that can help a real world problem. And, so I became kind of evangelical about it. I started talking. I set up an online group called VR Doctors where we talked about our experience. I started giving talks about the sort of experiments that I'd done. I did a project using Google Glass in a care home to remote cast care. Got a lot of positive feedback. So I thought, well, here we go. This is great. I'm finally getting somewhere. And then I burnt out like a mofo. Like I became very unwell. And that was in 2017. And the reason for that was I'd really seen the medicine that I wanted to practice. I knew at that point what I wanted to do. I wanted to do health tech. But could I find a way into it? No. And I couldn't do it in the NHS. So what I ended up doing was like loading up lots of extracurricular things, doing lots of other stuff and trying to do everything while my work was getting harder and harder. And I just overloaded, and it felt like it was June the 22nd, 2017. It felt like everything just went pear-shaped, and I just couldn't work. I just saw a patient. I remember seeing a patient came in for a hypertension consultation and a medicine change, and it took me 45 minutes. I just suddenly ran out of road and phoned in sick, and then spent 5 months off work, really unwell, like really depressed, really anxious, and needed a lot of help from my family, my doctor, from Wobot. I remember you mentioned Wobot the other day. I used Wobot, an early version of it, medications, and kind of crawled my way back into health. And when I did, I realized, this is, I can't keep doing something that I don't like. And just as it so happened, that was the point at which Babylon contacted me. Because I'd been speaking publicly before I'd been off about use of technology, and Mobasher Butt, who was the chief medical officer, got in touch, and I've been doing some testing of their chatbot and said, would you like to come and join? And it was a rather non-specific kind of role that I'd be coming in for. But I thought at that point, I might not have done it before the burnout. And I was like, yes, I would like to do it. And that was in 2018 when I joined Babylon as the director of digital health and innovation. And that was really the making. That was what I'd been looking for at that point for 28 years, was what I found at Babylon. I found brilliant people working on big problems with a real sense of positivity. Engineers, AI scientists, designers, researchers, commercial people. I hadn't quite realized how much I'd thrive in that environment, and I absolutely loved it. I met some wonderful people that are still great friends and colleagues, and then got working on this company that was scaling very fast. So it was a very exciting time, dealing with problems that had no solution, dealing with a public and a professional environment where I used to get very, very unpleasant messages from people about the work that I was doing, and criticism online and everything. And we were approaching this with an open heart and a really sort of bright mind as to how we were doing things. But Babylon was ruffling feathers, so it was a really interesting combination. But I got to help lots of doctors and other healthcare professionals and epidemiologists start working in digital health. Within Babylon, we set up the Clinical AI Group and then the Digital Health Guild, where healthcare professionals would work in product-embedded place, up to 50 of them at one point around the world. We set up a digital health governance framework, set up a digital health curriculum, really, really did a lot of structured work. And I worked, that's when I got most involved in artificial intelligence with the Symptom Checker, which was an expert system, then a probabilistic system, other machine learning, risk prediction tools, and then in around 21 and 22, large language models. This was my first introduction to large language models because Babylon was using NLP technologies to do note summarization in 2021 and 2022. That was working. It was, the things that you see companies like Tortoise and Nabla and Nuance doing now was happening in Babylon back in 2021 and working pretty well, but wasn't quite good enough to make it over the line. And so it never made it to market. And so we were still working with all these great technologies, learning an awful lot about it, about the realities of getting AI out into the real world. And then in late 2022, Babylon's growth and expansion started to hit the buffers in terms of the difficulty in raising funding and the fact it was dealing with very complex contracts in the US. And at that point, the work that I was doing in product management, my role was going to be made redundant in that role. And I had the opportunity to switch back to purely clinical. But, I'd spent many years of my life getting to a place that I really loved. And I took the opportunity at that point to leave. And I took a little bit of time off. And I thought, when I thought about what I was going to do next, I was like, I worked with brilliant people in a specific way on really big problems. I just want to keep doing that. And so at that point, I set up my consultancy, Curistica, which I believe is a very radical approach to clinical innovation, because got an enormous amount of clinical experience at this point, a lot of technology and industry experience. And now I get to work with other people in a similar space that really deeply understand all sides of the equation, but also give a shit, like really give a shit about getting stuff done, about finding problems and absolutely finding a way through to solve this. Working with startups and scale-ups and companies who have the same sort of passion. And that is where I find myself now, with a company that was initially just a wrapper around me, but I now have two other people working with me, Chloe and Tijal. Absolutely loving it. I'm really, really pleased and happy now because I get to study all the weird and wonderful stuff that we're going to talk about today, speak to people that are interested in it, like really sink into real world problems, and also work with, current and next generation healthcare professionals who want to kind of do the same thing. I want to help them, because this is really the most fun and the best medicine as far as I'm concerned.
It's a beautiful story, mate. The first thing that comes to mind for me is that nothing just happens, does it? Like, you don't just get to a better place. You don't just get the new job. You don't just get to meet your passion with what you do, earning money during the day. It just doesn't happen. And you talked really nicely about, getting closer year by year or move by move, getting closer to the thing that gave you fulfillment. And I don't want this to be a negative message. I want this to be a message that people earlier on in their careers can really take from you and understand from your journey, in that it's okay that the thing that you're doing right now isn't right. It's, on balance, probably the most likely scenario that every single person listening to this is in, that it's not quite right.
Yeah.
But that it's in your power to iterate your life and your career towards something better. I think that's really important. And I relate to that so much, man. Like, honestly, year by year, I was just trying to get closer. I was just trying to get closer to Healthtech. I was just trying to just add an extra string to my bow that would make me useful to that world initially. And then just getting closer and closer to that world through policy and all the rest of it. Like, it's such a good message for people to hear. I think what's really interesting in your story as well is that I think it seems like you had a vision for the world as well. And that was it was your North Star. It was what was driving you. It was what was giving you this like incredible fire behind you, and still does, by the way, that you have a certain vision for the way that you think medicine should be practiced, and the technological skills that can find their way into medicine to make medicine better. And that's driving you to do all of these things. I think what's interesting about, and I don't know how much you want to talk about this, but like the interesting, even if I just leave it at this statement, but the interesting thing for me about the point at which you hit burnout was that it's almost like you became plagued by that vision because the world wasn't giving you green lights towards it, and you were met with red light after red light after red light. You find yourself in a position where you can know and see and feel palpably the benefits, and the world just wasn't acting with you in that moment. And it's you know, that redemption story of, you know, Babylon coming along and then actually giving you what you needed, giving you that green light, and actually providing you that oasis in what felt like the absolute desert, is just so that's so nice to hear, because I think that's what so many programs are doing at the moment. Like Tony's clinical entrepreneur program, like, yes, you can talk about how good it is for getting funding and all the rest of it and building companies, but like at the end of the day, there's no doubt it gives people a community. It gives people a place to go to not feel like they're alone, to not feel like the whole world is against them, and to get ambition and to get those green lights and momentum from everybody else. And I think you were so early to the party that you didn't have a community of people around you that thought the same. And that can be incredibly isolating. That can be incredibly lonely. And for all that Babylon has done, I'm at least very glad that it's done that. And my goodness, did it have a community of people inside there that I know you've talked about before. You look at what everyone's gone on to do. It's like a who's who of health tech, like, and a what's what of health tech. The amount of companies that have spun out, the amount of people that saw true disruption. And that's the other thing that I wanted to mention quickly, which is like, you can criticize Babylon for a lot of things, but I think you had hundreds of people there that showed that were shown true disruption and what that actually looks like. You talked about Babylon ruffling feathers. Yeah, I've heard that in lots of different ways, that policy had to catch up behind Babylon very, very quickly. A lot of institutions needed to get into gear to actually figure out how to regulate things, or how to change policy to allow for certain things versus not others. It sparked conversations in that world to enable a whole branch of telemedicine that hadn't even been considered before, and AI and all these things. So there's so much that Babylon did that I think can get swept under as like, oh, well, it collapsed and it caused all this pain and which it did, and there's no doubt about it. But we can't ignore, as part of that story, the things that it has done to inspire so many people and give people like yourself purpose and a place, an oasis in the desert to put their mission and their vision and their skills. But yeah, I just wanted to give you those reflections, man, of like, yeah, getting closer year by year. It doesn't just happen. Like, yes, I think the world was counting against you where you had that vision, and that led to some of your burnout. But then, you know, Babylon and everything that it's done, I think is, you know, needs to be given credit for things as much as it needs to be given criticism. So yeah, I don't know what your thoughts are on those.
Yes, I agree with all these things. Sort of picking up a couple of things. I think the idea of a North Star is so important. but it's actually quite hard to do. You can have
Agree.
a sort of, and I'm fortunate over time, my North Star has become clearer because I've spent, I'm old, I've spent more time with it, trying to work out what it is and what it isn't, and so on. So if you're earlier in your career or your life, it can be hard. You can have a sort of sense of it, or maybe you've got lots of different things. And it's a little bit like having a big menu, like having a great big menu is great, but it can be paralyzing. Once you've got a bit of clarity, once you say, I can put my weight behind this one area, and it takes, guts to do so. So it's hard, but once you have that, everything starts to line up a little bit. And you're right. Once you begin to have a North Star, you have a sort of sense of which decisions take you closer and which take you further away. And all you can maybe do sometimes is take the decisions that take you closer. In retrospect, what will happen is people say, oh, look at these great decisions that you made. Look, it must have taken a great strategy to go from here to there. And you're like, but yeah, I'm fitting a line to this sort of thing that happened. There's a couple of great quotes, and I'll probably mangle them here right now. But one of my favorite quotes, I think it was Pasteur, that said that chance favors the prepared mind. And I love that. I think it's a bit before it's saying, like in the field of discovery or something, chance favors a prepared mind. But the chance that led to the big change, Babylon, favored the prepared mind. In this case, I was prepared because I'd been talking, giving of my time, speaking and everything. And I just happened to be lucky. But I'd been working very hard on things that felt that they were going in the right direction. That led to this. And so a lot of people who want to get into health tech now, because there's no sort of formal path, at least no clear, it's getting a bit better, but it's still all about meeting people, giving of your time. And it's a wonderful thing to do because everyone else in your tribe, I keep coming back to the word tribe, and I said it when the first stand up at Babylon, says, after 28 years, I've finally met my tribe, people that feel and think about healthcare the same way that I do. It takes some time, but once you get there, then you start to increase the number of lottery tickets that you're holding, because you've got people that are sort of pulling in the same direction of you, and giving of your time freely and helping others kind of pays back. So the networking aspect's good. The other quote, which I like, and this is from just like literally the other night, I saw Monkey Man, which is a new film by Dev Patel, which is a kind of John Wicksian revenge thing. And I recommend it to everyone. It's great if you like that sort of thing. Very gory. But in it, there's a line at one point, a sort of the training montage type thing. And the line was along the lines of, pain will leave you when it has finished teaching you. And I've been thinking about that and thinking, the sort of discomfort that I had, everything, all the way, even up to the burnout, all taught me important lessons that contribute towards that which makes me valuable just now. So even the missteps along the way have added to my value just now, what I can do. And then when it comes to just this sort of North Star, yes, it's like Simon Sinek, who's a sort of marketing guru and kind of presenter, talks about, start with the why. Why do you do this? Why do you get up in the morning? And then work backwards from that, as opposed to just thinking of all the pieces. And for me, there's that kind of Star Trek idea of a kind of post-abundant society where everyone gets all the healthcare they need or whatever they need, and there's no money changing hands. And, it's a science fiction concept and lovely and utopian. If we did want something like that, what would it take to get there? So I start with that. It's like, I want to get to a point where everyone can get the care that they need. I genuinely don't care how we get there. And if that's a world that's 95% AI with 5% humans sort of touching up the details, but everyone gets that, fine by me. And I think you free yourself up to think radically that way. I'll just take that position. There's plenty of other people that take other positions, and then we can work it out as we go. So, I enjoy that. Once you have clarity of why you do things, roughly where you're going, and just take decisions that take you closer, that smell better and not smell bad. Don't worry too much about if you take the few wrong steps. You can get there.
Yeah. Right. Babylon. How do you feel about what happened now? I think, a bit of time has passed. Things have been relatively quiet on that side of things. The news cycle has moved on. How do you feel about what happened there? And I guess all those people, all those innovators, those innovative clinicians. And I think the question that I've got is, when you were inside Babylon, receiving that negativity often, knowing in your mind that your intentions were good and you are part of that machine, is that what true disruption looks like? With that vision that you've just talked about, we want to get to a place where was it a case of like you feeling like, I'm happy to roll with these punches because I know the intention, I know this takes us somewhere better? Is that what gives you strength in that moment? Because I've written a couple of Forbes articles where people have like got in touch with me and been like, you worship the god of profit, like what are you doing saying some of these things? Like it can be really sort of, it can take a real hit on you. That sort of stuff.
It can be very personal.
It can, absolutely. No, completely agree. And so how did it feel at that point, and how do you feel now, like since everything has passed?
So there was the sort of the white heat of the criticism was mainly, it was pre-pandemic. It was close to pre-pandemic. At that point, Dr. Murphy was his name online, Dr. Watkins, who was a prominent critic and would point out failings of the chatbot and would do so regularly, and was unhappy with how Ali presented things in terms of what he felt was hype and so on. So that was all happening in the background. And, at that point I was on Twitter a lot, and I did what I could to sort of engage calmly and professionally with it. And it was hard at times because it felt quite personal for the reasons that you said. For the team that I was working with, everyone was absolutely laser focused on making this safe and effective and working very hard towards that. And then people were pointing saying, you're clearly, cutting corners and everything. And, I've got the scars of working with the regulators and the safety team to say that there was no corner cutting. It was extremely hard yards to get this. But it also felt a bit difficult because you were still slightly limited in what you could say online. It was a real interesting lesson in communication as well, is that how I might have approached it, being a wee bit more open potentially, and felt, or at least perceived, that it was the way that I shouldn't be approaching it. I did many times invite people to come and meet with me and speak with me, including Dr. Watkins and so on. Actually, interestingly, I don't know if you've had Dave Triska on the show at all, but he's a fantastic GP and technologist. And when I put out the invitation saying, look, come and speak to me, I'll show you, he took me up on it. He actually came in and spent a morning at Babylon and met everyone. And, and it's turned into a good friendship and some communication with him. He didn't, there were some things he didn't change his mind about, which is fair enough. But at least I think he felt that he saw that we were approaching it with, openly and honestly. I did get lots of really horrible messages from people, some people that I really respected as well, saying that I'd gone to the dark side, that I was pursuing money and all this sort of thing. And part of the work that I did when I brought doctors into Babylon was there was an element of supporting them as they started to sort of feel a bit like they were no longer doctors, because they were quite often getting similar grief as well. Over time, there's a few things that I've come to appreciate, and one of which is the kind of the money side of things. When you're in the NHS, you're in a very kind of privileged position not to have to think about the money quite so much. Now, that's not entirely true for everyone. You're constantly thinking about the decisions you're making at a population level and making the right choices for the person in front of you and so on. But you are pretty much guaranteed that someone's going to pay your salary next week, and and your pension's going to be paid and everything. And that means that you can sort of stop thinking about the money side of things and even start to think of money as a sort of distasteful thing that should never be mentioned alongside healthcare. But the truth of it is that money is critical to delivering healthcare. If you want to provide care for people, money has to change hands at some point. The business has to run. And so when I speak to doctors these days who are wanting to come into it, I say that it's important for you to think about the commercial aspects of the work that you're doing as anything else. Because if you somehow chanced upon the cure for cancer, but you hadn't thought about how this cure for cancer was going to be built, marketed, paid for, how the business would run, who was going to pay for it, if you thought that's just distasteful, that's just money, this is a great thing, it's just as immoral not to think of that as not to think of making sure that it's equity available at all. Because if it isn't going to persist, if this company is not going to live on, people are not going to get your solution in the same way as if you hadn't invented it or didn't make it to anyone else. So you have to factor that in. It is as important a part of it as anything else. And once you start to understand that, you can start to feel more comfortable about openly talking about money and who's paying for it, whether the thing that you've built is a priority for the people that are paying for it versus someone else. And it takes a little bit of time, but this developing commercial sensibility, which I think is most easily developed by actually working in a commercial setting. I don't think it's exclusively so, but it becomes much easier, is one of those things that when I speak to companies about getting clinicians to work with them, that they try and find clinicians with that commercial sensibility. Not that they're money obsessed or anything like that, but they understand the importance of funding and business to getting the solutions out there, to solving the problems. And so hopefully that helps the listeners and you understand that kind of move that people have to make. That I don't know if it's uniquely difficult in the UK because of the NHS and how we've been trained and how we think about healthcare, but it's certainly quite pronounced here, much less pronounced in other countries.
So it seems like Babylon then, via you and others, would then give those clinicians that moved over that kind of commercial education, they end up looking at healthcare in a different way. And then, dare I say it, are able to actually spot a lot more opportunities. Because if you look at the people from Babylon that have gone on to do various things, it hits me like a ton of bricks. You guys saw what true disruption actually looks like. You become au fait with, yes, you're going to ruffle feathers, but you're going to get somewhere arguably better, or at least we're going to learn something. So you see and you visualize true disruption. So you start realizing, hey, industries can be disrupted. Old processes can be replaced by new. It starts to show you that, like, hold on a minute, this can actually happen. So now you've equipped this incredibly talented group of people that has a multiple skill set anyway. You've then showed them come at the commercial side of healthcare, given them permission for the fact that that commercial side of healthcare is what creates impact, and you shouldn't feel bad for it. Actually, you should find a way to harness it. And then you get the likes of Daffod starting Concentric and Blast, like,
of course, yeah.
all of the people.
And Daff's a great example because, Daff was actually working, when I arrived at Babylon, Daff was there. He'd been there for a little while. And so actually I learned, some of my onboarding at Babylon came through Daff. And Daff's got a really, really clear idea of doing things the right way in a sort of step-by-step, well thought through process. And he's turned into the most incredible sort of CEO and founder with a real open heart as well. If you've been to any of his talks and he talks about how to get there, he's a wonderful person to listen to because he thinks deeply about this and about what it means to deliver care and to make changes. I think he's learned a lot along the way about the business decisions that you have to make your great solution real. I think, when I think about disruption, it's interesting. So people say, well, the healthcare is too important to invite disruption into it. But then when I was working as a GP, one of the hardest things and one of the things that contributed towards my burnout is that I started to realize that the best I could ever hope for with my patients was to compromise the least with everyone. It was never an aspiration that there's so many things that I could do for the person in front of me if I had the time and if I had the resources, but I had no time and I had no resources. So it was this sort of mad scramble to get the best out of what little I had with them. And that's pretty dispiriting when you're doing it, like patient after patient after patient. And then, I was in my mid-40s at the time, and you're like, and I'm looking down the barrel of 20 years, that's about as good as it gets. That's hard. And at that point, people say, well, you can't disrupt the system. I was like, what? I can't disrupt this system that is failing so many people every day. And we're just accepting that is okay because that's the cost of delivering it in this particular way. No, absolutely not. I'll find a way to do this. Now, sometimes that disruption comes to place and you want to do it. If the cost of the disruption is pissing off the incumbents, but helping patients, you just have to take the blows, and kind of that's a wee bit how it felt. I remember I gave a talk at the Royal Society of Medicine. It's the day that I met Dr. Watkins for the first time in person. And we were giving a talk, and there was a sort of panel discussion afterwards. And it's my claim to fame that I got roundly booed at the Royal Society of Medicine because I was saying something along the lines of this, I refuse to sort of settle for a place where, and the line I said is like, patients are told that there's only one problem per consultation. Now, I know may not be true right now in some practices, but I had literally 2 days before been working, or 3 days before been working in a practice, which had that in a piece of paper on the door of the room that I was in, one problem per consultation. And I said this and was booed and like, no, this is not right. You're lying. And I'm like,
wow.
Okay, so, the people who are working in the system are denying the very reality of something that I'm trying to work against. I'm just going to have to take the booze. And I'll continue to do that as long as I believe that I'm working in the right direction. Because with that, we disrupt the parts of care that are leading to care persisting and not being as good as it could be. And again, how am I going to get to that North Star? Doing just more of the same thing is not going to get us to that point.
It's so difficult, my God. Being booed on stage for something that you believe in, God, that's a double-edged sword, isn't it? Like, in that moment, that must be so difficult, especially by a group of peers, people that you respect, and for a vision that you have based in truth and reality, and your truth and reality, and objective truth and reality as well about certain signs on doors. I think it's fascinating. It's fascinating to me that Babylon was able to do this. Babylon was able to sit inside our healthcare system and wind people up this much. I think it's so fascinating because if you want to press the buttons of your mate, you'll pick on things that, they sort of feel a bit like not great over, and then you'll take the mick out of it and you'll get a rise from it. And if one is triggered, one should always, examine why it is that they are triggered. If one is insulted in a foreign language, one doesn't react because they don't understand those words. They mean nothing to them. The words that do mean something are what can be most painful. So for me, when I hear that you were booed in the Royal Society of Medicine, it was touching a nerve, wasn't it? Clearly, or maybe not clearly, arguably, but clearly to perhaps you in the like. And I think that's the thing. You have there an old guard. You have a something that was like literally, by definition, truly disruptive in that room. It disrupted the peace that people have, and healthcare is so full. You and I know this, even in health tech, it's so full of I agree. Or like, can you say that? Like, can you not? That's about as far as it goes. Whereas, like, it's wild to think that at the Royal Society of Medicine, you had people on stage, like, talking about technology, getting roundly booed. Like, there's part of me that's like excited by that. Like, where are the LLM people currently, like, evangelizing that and getting booed? Like, the VR people. It's so interesting.
I think Ali is coming for a bunch of criticism, and I won't, argue for him for some of the things that he's been criticized for. But what I will say is that Ali did a fantastic job in creating a vision and a mission and bringing people together to work on it and supporting them to do so and standing up and calling out things that touched a nerve and being strong enough to see it through and being disruptive. He was a Marmite character. Some people loved him, some people didn't love him. But things changed. And of course, what happens now is that now that the dust has settled somewhat and Babylon has not been on the winning side on this, at the very least, people talk and say, well, what Babylon did wasn't all that big. Like anyone can do video consultations. It wasn't even AI, what they were doing with these expert systems and probabilistic models and so on. And because we're around less to discuss it, that becomes the story. Yet, while I was at Babylon, I remember being in the room with people in positions of authority within the health service who were literally threatening to refer me to the GMC for doing a video consultation, saying it was immoral, saying this is crazy, this is dangerous, this should never happen, are the same people who now say, well, we do it anyway, this is easy, of course it was always easy. But you know what? That's it. That's the way it goes, and sometimes I think I've talked to you before about the Good Shepherd hypothesis of the solar system. Did I talk to you about this? Yeah. And for those that are listening right now, it's a debunked theory of the solar system that life emerged on Earth because we had Jupiter in the early solar system with its huge gravitational pull absorbing its lion's share of asteroids and comets and so on, which meant that the Earth didn't get pummeled so much and life developed. Now, Babylon was a big nasty for some people, drew a lot of attention, a lot of asteroids and comets, allowing other people to grow up in the side as well. And then for those people that then go on and do something else, and you've mentioned some of them as well, all of these things, they came to Babylon because of their passion for the mission, their skills, they got to work with great people, they've gone off and done other things as well. They know what to do. They also know what not to do as well. And that's very important too. So I'm really excited about seeing what my colleagues, former and current, go on and do right now, because we still need a lot of change, don't we? Healthcare really needs some help. And we've got a lot more people doing it now, which is great.
Completely agree. And I think it's interesting when you consider the technologies that are going to come over the horizon. We've seen LLMs, and we're going to talk about that in a second, but whatever the next one is, and the one after that, and the one after that, when everybody starts turning around and saying, no, that's not how this should be done, that's not the way we do it, that's not okay, just remember that consciousness shifts. And for people listening, think back to that telemedicine example where completely legitimate people were threatening you to go to the GMC for doing a consultation over video when that is the norm now. And that's because new things are scary. New things are scary, and we have so many assumptions baked into how we do things that often when new technology comes over the horizon, people think, well, how does that new technology make what we do now better, but still exactly the same? It needs to just be better quality, but exactly the same. And it's actually the fact that new technology changes the way that we do things, and that people just haven't seen that yet. I don't blame the people that want to be the laggards with new technology, or the fast followers, or I don't begrudge people for criticizing and asking legitimate questions about, but how is blah going to be blah? I think that is all very reasonable. But I think in healthcare, you're absolutely right. We need to be a collection of people that has an open mind to new technology, and I think that's the bit of work that needs to be done at scale, which is there are people, there are innovators, and there are entrepreneurs that are going to just dream things up that none of us mere mortals could have the ability to do so. With that, we need to keep an open mind and actually put the wrapper around those people and those ideas that means that they actually see the light of day. That's what I think becomes important. And I think you're such a good example of that, Keith, as someone that can kind of translate that tortoise vision and just give it to the people that might not understand that quite yet and that have reservations, and communicate the fact that this is a process. This doesn't just happen overnight. We are going to listen. We are going to do those things. And, I've heard Dom from Tortoise talk about, he just goes around the ward asking people what they're worried about, which is just like a wonderful example of doing that.
Dom's quite something, isn't he? And Dom probably won't mind me saying this, but, I advise Tortoise, and that's the only company that I've approached to say, can I be an advisor? People often ask me, and I was like, I saw what they were doing. And in particular, having heard Dom speak, Dom's got the right amount of kind of clinical background, brilliance, sort of clarity of vision, but also, a real willingness to say, but this is what we're doing right now isn't right, and no, we're going to try something different because I think we can do things better, and is happy to stand up and say that and take some people pushing back, because people do. That's what's needed. And so I had to get taste of that action, and they're doing good stuff. But also blending, it is also true that, you know, it's not true that all new technology is great. Of course, it's not. So we do have to have people pushing back and doing things the right way and evolving things too. But the disruption side of things is interesting, because people say, you know, healthcare is too important to disrupt, or it's too, you know, you can't, or that move fast and break things is a great line. And I still think that's, you know, incorrectly applied if you put it in healthcare. But when people said, oh, there's no space for moving fast and breaking things in healthcare because it's, you know, people are, you might damage people. That's willfully ignoring the fact that people are being damaged by healthcare, how healthcare is delivered right now. You know, we heard on the radio earlier on today, the health minister was being interviewed, and there was a report saying that 250 people per day are dying as a result of the extended waits in emergency departments. It was something a little bit like that, but it was a significant number. Nothing wrong with breaking that. I'd happily try and do something to break the fact that 250 people are dying. You know, like, why can't we fix that?
Yeah.
You know, that's, you know, that's one way of interpreting it. We do have to be righteously indignant and unhappy about things the way they are, and feel empowered to be able to make some changes, because it affects me, it affects my family, it affects your family, people that we care about. You know, the next generation of people working in healthcare are really fed up. You know, we need to give them hope that the way that things can go can be better. And that requires changing some of the things that really don't work right now.
So you mentioned Tortoise, so Clinical Copilot, you mentioned a few others, Nuance, etc. AI and large language models. This is the big new technology. Again, there's been a little bit of time for dust to settle now. ChatGPT's been out a while, and we've had this sort of public access to it. I spoke to Hugh Harvey a couple of weeks ago, who described it as it feels like we've rediscovered fire and we've just got no idea what to do with it. There's a lot going on with large language models, and I spoke with him about, you know, the interface of them being medical devices and being close to patients and all those things. But I know that AI and large language models, this is sort of your specialty now. And so I guess we've got a bit of time. So why don't you start at the beginning with AI and large language models? When did you first, in fact, you mentioned already, like what was your feeling when you first started looking at large language models? And, you know, 3.5 comes out, GPT 3.5 comes out, it hits the public domain, and then Gemini and all these other things. People are, you know, using it to diagnose their headaches online, and people are starting to use it for this potential application, mental health chatbots. Like, oh, maybe these could be large language, or maybe all talking therapies could now be this could be at scale. Like it can be clinical decision support, it can be diagnosis, it can do loads of back end, it can do everything in healthcare. Then you know that the hype's kicking off, all the potential use cases are kicking off. It's a bit all over the place, and it all just becomes incredibly overwhelming. I think that we are starting to cut the wood from the trees now a little bit with things like, hold on a minute, it can't diagnose and treat because it needs to be a medical device. It's black box. We can't look inside it. Therefore, in its current architecture, I'm not sure we can use it as a medical device. So that's starting to emerge now. Perhaps we use it for everything else. Like there's a question mark around it displaying empathy even at the front line, and we're starting to see some things now. But I'm interested in your view from when you first used it to now. What's been your experience of playing with large language models to then actually, you know, giving us a great talk on LLMs in healthcare and the past, present, and future of it, for example? So, yeah, go through some of that for me, Keith.
Yeah, I think large language models have caught the public imagination because it's the first time that AI has behaved like people think AI should behave.
Yeah.
As in, you ask it a question and it says something intelligent back. You know, we've had tremendously powerful AI technologies beforehand that do incredible things. You know, with voice recognition, image recognition, predictive tools. You know, a lot of these AI technologies have made it into our daily life to the point that we don't even think about it anymore. And I think Sam Altman, who's the chief executive of OpenAI, said it best when he was talking about he's always impressed at the ability of humans to rapidly discount almost miraculous technologies as routine. You know, like one day you're like, oh, this is incredible. And the next day it's like, well, it's not that great. You know, our expectations accelerate. So when did I first come across large language models? Like late 2021, early 2022, when I was involved in some work on large language models within Babylon, on what was called the note assistant. It would, transcribe the consultation and create summary notes as well. Now, I probably didn't appreciate how transformative that was, because I was just seeing, like, again, the one thing that it did. We have this AI, and here it go, it's doing this one job. And it was impressive and really, really helpful, and started to understand a little bit more about hallucinations. That's where we first came across hallucinations, omissions and hallucinations in the transcription, and trying to find a way to manage it. But a lot of the technical work was handled by the AI scientists and researchers and devs. So I didn't quite see under the hood in the same way as I have more recently. But then, so two things happened in November 2022. Like, GPT 3.5 got released on, I think, the 30th of November 2022. But just before that, or around about that time, I was a panelist on the AI all-party parliamentary group talking about AI and health. And it was just before I left Babylon. I remember preparing my points to say, you have this little 5-minute talk to the ministers, and then you answer questions. So the things that I wanted to talk about, and I wanted to talk a little bit about large language models. And Saurabh, who was the chief science officer at Babylon, I remember speaking to him and saying, look, I have this opportunity to go and speak. Like, what should I cover? And he said, I'd emphasize the large language models, they're really, really important. So I went in and said my bits and talked about it. And I emphasized the importance of the fact that the developments in AI were such that we have some feelings about what data is used and where it can be used and so on. But in the face of accelerating technologies such as large language models, there's going to be geopolitical implications about whether you allow things to be developed or not. And we have to start thinking about AI in that sense, as in these are extremely potent technologies. Then lo and behold, like November the 30th, GPT 3.5 launches and everyone loses their mind. So I was very fortunate to get the sort of timing of that right. But GPT 3.5 was when I first got it as well. And I think the reason for that is because OpenAI's team, it was the user interface and the sort of instruct model that you could talk to it in a chat interface. That was the thing that made the difference. And then all of a sudden, using plain language, you could get an AI model to do a number of like near miraculous things or really impressive things that you rapidly started to see the gaps in. But at that point, it was like, holy smokes, this is incredible. Went away, started to try doing some things with AI. But it was GPT-4 there was like a 2-week period when GPT-4 launched. I swear I had about 3 hours sleep a night because... And Ethan Mollick in his book talks about, Ethan Mollick, we may come back onto him, says that until such time as you've lost sleep over AI, you haven't really kind of got what's happening. And I know what he means. So GPT-4 came out, and I remember I was late for an evening meal because it launched and I was playing with it. I was like, do this. And then that week there was like Google did a launch, Microsoft did a launch, 2 weeks of like this fire hose of new stuff. And I was able to use GPT-4. For example, I remember one morning I was playing with it and I thought, I wonder if GPT-4 can help me create a Telegram plugin, Telegram, the messaging service. And I don't know how to program for Telegram, that would put a triage in it. So I was thinking, well, if you're in Africa, sub-Saharan Africa, you might have a phone that has access to Telegram. If I had a Telegram interface, I could do that. And so I used GPT-4, and in about 45 minutes, built a Telegram plugin that allowed you to ask questions, and it would go through to GPT-4 and come back. And so I could use it for medical triage. And I was very pleased with myself. And I was a hair away from posting on LinkedIn saying, look at me, look how great I am. I've done this. And I stopped because I thought, actually, the need for healthcare in sub-Saharan Africa by people who have access to Telegram is so high that even if I say, oh, please don't use this, this is just an experiment, someone would just pick it up and go, you know what? I'm just going to do it. And that really excited and scared the heck out of me.
Interesting.
Because all of a sudden, like, I'm not a developer, but I was able to do something very, very powerful that's potentially positive and negative, and just get it out there. And that's when I thought, now I really need to understand this, and spent a lot of time understanding how the models work and prompt engineering. And then thought, well, what I need to do is tell other people working in healthcare how to experiment with it so they can at least understand this technology and be active participants in the development as opposed to passive recipients of it and lose control. But that's how I got into large language models. And since then, it's been trying to keep abreast of the changes, which happen very fast, and experimenting and then talking about it like we did at your workshop and in other places, helping people understand the very basics, and then the basics of prompt engineering, how to instruct these models, so they can go away and safely experiment with themselves, and they're closest to the problems in the real world. They can start thinking about how this will work. And that's roughly where I find myself now.
For clinicians and people in healthcare that are listening, the simplest that I've ever heard it explained of how they work is that this is glorified autocomplete. That is obviously incredibly simplistic. But as someone that kind of understands it to a much higher degree than that, what's a slightly more padded out explanation than that of how these large language models actually work?
Yeah, I suppose saying it's a glorified autocomplete is it's actually not too incorrect. All these models are doing is essentially looking at some words or some parts of words, tokens, but we'll say words for convenience here, and then predicting the next one, and then looking at everything and doing the next one, and then the next one, then the next one. So yeah, kind of autocomplete. But under the hood, the thing that's really impressive is that how these models know what the next part of word to use is based on being exposed to like an insane amount of data. I mean, like truly mind-scrambling amount of data. We're talking about trillions and trillions of tokens, or trillions and trillions of words to make it convenient. And understanding the relationship between how one word or two words or three words lead to the next word, but also which of those preceding words is most important to predict that next word. And by having a computer model that over time and training learns that association and therefore becomes very good at it, and is also how it's fine-tuned to answer questions as opposed to just complete documents, is complex and like staggering. That just this sort of, and I'm going to say simple, of course it's not simple, but simply by understanding the relationship between one word and the next and the words beforehand, you can get something that appears tremendously intelligent. However, if you think that, well, that's just autocomplete and, that's not intelligent, it's still incredibly useful. Like, a calculator is incredibly useful. A screwdriver is incredibly useful. It's just a piece of metal, Large language models are incredibly useful if you find the right tasks for them, because they've found the sort of underlying pattern of how we use language and access to enormous amounts of knowledge, and therefore allows us to do autocomplete, but based on not quite the entirety of human knowledge, but a lot of things that you don't have from other areas, and knows how to use the language. And that can be incredibly helpful. I've just read a book, Literary Theory for Robots, How Computers Learn to Write, by Dennis Yi Tenen. And he goes into this in a little bit of detail. We got quite a lot of detail in the book. It's not a very easy book to read, but he talks about large language models as being the sum of human effort, because lots of people have created all this content, and then we've had people creating the machines that find the patterns between it. Large language models aren't intelligent beings of themselves. You're just standing on the shoulders of everyone else to achieve something more for yourself. And that is very, very helpful in a whole bunch of different situations. The important thing now is that we teach everyone in healthcare, everyone else, when using that tool can be done safely. Yeah. And that's what we're working out just now. Yeah. How it can help us with the things that we find hard to free us up for the things that we find easy or important.
Yeah. So what do you think the significance is for healthcare? Because as you say, we are trying to find the use cases we're trying to split like what are the non-negotiable human things, and therefore what is the everything else that that large language models could be part of. So yeah, what do you think is the significance? I think the answer might be different to like right now versus 10, 20, 30, 40. Obviously, it's going to change through time. So what do you feel is the significance of these in healthcare right now?
There's a few things. If you think about anything, so if we've got doctors listening to this, I'll maybe talk to that because that's the example that I know myself, but any healthcare professional will have their own encounter, or even actually just as a patient when you're speaking to a doctor or a nurse, what's happening in that consultation. And think about the things that are difficult. And the things that are difficult for me, so if I'm a locum, an occasional doctor, and then, James, you come in to see me about something, I don't have time dedicated beforehand to read through your notes and fully understand what's gone before and everything. So in between the patient before you and you, I will quickly look, why has this person come in? What are the headlines in his medical history? What was the most recent consultation? Are there any recent letters or anything like that? I'm scrambling to try and, with one of the two big medical systems that we have here in the UK, which are not terribly easy to use. Scrambling to try and get that together, to sort of get a little bit of a story together, to put me in the right place, to receive you, to start hearing what you want to talk about. And then while you're talking to me and we're having a conversation, I'm trying to listen to you, but I'm also weighing up what's gone before, but I'm also thinking about what questions I need to ask. And I'm also thinking of writing it down either as I go or, putting it in place. So I'm not fully attending to what you're saying. I'm also trying to draw on my memory for important knowledge. I keep some of the knowledge in my head, but some of that I have to go elsewhere. So I'm juggling all of that. And then I'm examining you, and then I'm thinking about where I need to send you and having to use more technology. So you can see where technology intrudes on all of those things, where ultimately what would be really nice is for me to have all that information to hand, for you to come in, for me to say, right, I've read this information. I know about you, and I know about you from before. Let's properly listen to you and hear what you have to say. You've maybe been assisted in getting your story, in line. All the information that I need to have at hand is brought forward just in time for me to be able to put it there to share with you, so we can have a discussion about it. That's where I think large language models can help, because large language models can help by summarizing the information that's gone before in a form that I can understand, potentially showing the information that's being shown to me to you as the patient before you come in, to double check that this is all correct. Is this an adequate summary of what's happened before? Is this an adequate summary of what you're talking about today? With ambient documentation, such as provided by Tortoise, all this transcribed, so I'm not having to write it all down, that it's summarized in a set of notes that I can review and put over afterwards, that I have large language models attending to what we're talking about and intelligently bringing in the right guidelines, the right research, taking the information and highlighting the things that I haven't brought together, which is why I think that we need to move towards not a two-way consultation, but a three-way consultation between the healthcare professional, the patient and their family and carer, and the data or the AI, like a three-way conversation. That means that I'm using the thing that is uniquely important about me as a human in this, that I'm listening to you. You'll feel that you're being heard, that I am the doctor, you are the patient. There's that transaction happening. There's the opportunity to empathically listen to what's happening, to help weigh decisions, to bear witness to a person's story, but equally have all the important data provided in the right way and captured. I think that is the promise of large language models. Components of what I've just described would undoubtedly be a medical device. And as Hugh, who knows a great deal about this area, will have said, there are challenges there. But there are some aspects of it which are less clearly medical device.
Yeah.
And what we might be able to do is use some of that administrative support in the meantime to then just sort of offload some of that pressure, and we can start moving towards, that conversation. I sort of describe it as, to get back to where we were, as in how medicine kind of used to be, we have to let go of where we are. And even though doctors will complain to me about the fact they have to write notes on anything, they're terribly attached to it. Like if you say, I've got something that will free you of that. Like, I don't know about that, So, we have to be able to let go of some things. But that, I think, is the sort of short to medium term vision for large language models.
Yeah.
As really powerful assistant.
Yeah. And it's good positioning as the powerful assistant. Because the elephant in the room with these things is that you hear these stories, don't you, of my child had an incredibly rare disease. I uploaded the transcripts of all of their last 5 consultations to ChatGPT. ChatGPT gave this amazing diagnosis of this 1 in a million disease, got tested for it, and it was right. So therefore, ChatGPT is an amazing diagnostic tool. Why isn't it just diagnosing everything? Why don't we take that ambient documentation and just let it run ragged on diagnose? Even saying these things like makes me cringe, like saying the word diagnosis next to these things. I know the MHRA might be listening, but yeah.
Yeah, but that's is it in some ways you can say, well, diagnosis is only something that a clinician can do. They're empowered to make it, and a machine cannot diagnose. Like, by definition, a diagnosis has to come from a human. Therefore, these machines don't do it. But they certainly support diagnosis and influence things. It's interesting, the stories like that. The rare disease that leads to this discovery. But equally, what if they put it into GPT-4 and it said, oh yes, it could be this rare disease, which requires your child to have a bone marrow aspirate and a lumbar puncture, and if it's not that, and then a person's got a painful, distressing procedure that has a certain morbidity and mortality attached to it, that could be a problem. Or what if it's it's a wild goose chase on a very expensive or difficult path, so there are downsides to it, of course, equally with all these interesting things. Although that said, I'm speaking on the 1st of May at an event on medically unexplained symptoms. And I think large language model, it's similar to what you're describing with children here. It's like rare diseases in adults and adults with functional disorders and so on. So I'm going to talk a little bit about where large language models could help there. And they hold a great deal of promise for exactly what you've just said. Like, given all this information, and given these diseases that I've ruled out, what am I missing, kind of thing. And it can bring that to the server, and then you can weigh it with clinicians like, well, it's suggesting this, but actually that's very unlikely and we can't go this way, or why don't we try this? The other thing that I think large language models can do is actually help people with complex medical histories tell their story. Because you maybe have had in your own career, and I've certainly had this, is that I meet a person for the first time, particularly if they've got a rare disease and they've generally got a really ragged piece of paper, or more recently, like something on their phone. And they'll say, well, I've got disease X, and I carry this piece of paper to help doctors who never know what it's all about to do so. And it's got a list of all my history. A large language model, that's been written up often by a patient, maybe in a way that's difficult for me as a clinician to absorb and bring up, but actually having their story translated into a form that would help me more rapidly get up to speed could be really helpful. So yeah, I think there's definitely something in the rare disease area. And one of the other books that I'd read, there's a few books that I can recommend and maybe share in the show notes. The AI Revolution in Medicine, which was a book that came out in early 2023 and looked at GPT-4. And I was saying before, I was queuing so long to get into the US at the time that I managed to read the book in the queue. But it's also quite a good book. Talks about rare disease. That's a perfect use of large language models, particularly rare genetic disorders and so on. And of course, a model that is trained on large disease databases and so on could be very good at that.
It's really interesting because it's funny, like even the tone in which you answer that question, and you acknowledge, yes, some of this might make it a medical device, but you're very practically talking about outcome. And you're saying, if we just have a sensible conversation, we use it as part of the team for what it is, and then it engages as part of a three-way conversation, that suggests it's talking to the blah, blah, but it's only talking to the clinician. But like, a three-person team of patient, clinician, and AI, what you're saying is like, if we just have a sensible conversation here and the AI is presenting some information, that information is taken by the clinician can then act on it as they please. Like, it's a very sort of considered way of thinking about this. Yes, there are definitions that would say that, well, if the AI is presenting information to the clinician, it's clinical decision support, it's providing a signal. That signal is being interpreted by a clinician, much as an ECG machine will produce a line that the clinician reads. The AI is producing a transcript which the clinician reads. The clinician is making inferences on the transcript or the summary or the outcome. Therefore, if we can't trust the signal, it can't be trusted support. That aside, what you're talking about is that if we were to trust it, that actually that becomes, as you say, an incredibly useful, arguably perfect way of using large language models to give extra information that can then be acted on to fill in a gap that the clinician may or may not have thought of. I think what's interesting about this conversation that we're having now is that this provides something that I think is so needed right now, which is hope. Because I think that what large language models have done is they've enabled an entire cohort of clinicians. By cohort, anyone sort of economically active in medicine right now. It's enabled like an entire population of healthcare professionals to have hope that maybe we might not need to ever make notes again at some point soon. Maybe we will get a little note that reminds us of the red flags we didn't ask before the patient leaves the room. So we just get a little ping, reminder to ask about PR bleeding. So then you're not worried about litigation the whole time and you're not practicing as much defensive medicine. Like, oh my God, maybe I can actually face the clinician for the entire consultation and actually speak to them more. Maybe that'll give me some time. Maybe I can move from 10 to 15-minute appointments. I think what this has done is it showed us a world that it's allowed people to just have a figment of their imagination. Imagine a world where things are slightly better on the workforce. And yes, there are the naysayers. Yes, there are the people that see things in black and white. Yes, there are the people that will say, well, it's not a medical device. It can't be a medical device. It won't be ever, which I'm sure, you've been booed on stage at Royal Society of Medicine. Things can change. So like, oh, yes. I think it's interesting that there's hope now. I think it has to be tapered with, let's hope that people aren't just going on ChatGPT going, this is the type of headache I've got, what shall I do? Maybe that is, I don't know, I don't want to speculate, but like, it's interesting, right?
Yeah, I think so. So a couple of points to sort of say about that. So in terms of objections to technology, remember that when the thermometer was introduced, it was roundly rejected by the medical establishment because it was felt to diminish the art of measuring other symptoms of fever and reducing it to a simple number and the danger of having. I don't think they worried so much about mercury then, but there's a lot of technologies that took a long time to come aboard. I believe the ECG went through the same, the stethoscope went through the same, and these are just other tools that come in. All that aside, I agree there's hope that how we do things now will get easier. And that's great, that's hopeful. But that's not the bit that makes me excited. The bit that makes me, the least exciting bit about all of this is digitizing what we do right now. I mean, that's fine. I'm excited about how would we do things differently given that we have these new tools. So we talked a moment ago as it's like having a third person in the room. Like you said, the AI wouldn't talk. Well, why not? Why not have an AI with a voice interface that the doctor and the patient are speaking, and then the AI will interject and ask questions of the doctor, ask questions of the patient, ask questions of someone else. You don't need to have just one AI. It could be multi-agents. You could have 1,000,000 or 1,000 or 2 in the room performing different roles, summoned and discharged as well as possible. The idea of a consultation that's time constrained at all may go completely. Instead of it being 15 minutes, it's a continuous consultation that people dip in and out of, that sometimes a person will be in the room and at other times it will be the AI and, a person at home. So you worry, you were saying about, you forgot to ask that question about rectal bleeding or PR bleeding. We could stop worrying about trying to cram these questions into the consultation, because they would be handled afterwards. And if there was any issues, it would be brought up. And the compact between the patient and the doctor was that we're not putting all our bets on this 15-minute, 10-minute talk. Actually, if we don't cover it in this point of time, that's okay. It's being covered in between times. Anything that's important will be raised. I could be summoned back in to address things. I get excited about that, moving from this kind of very intermittent continuity of care to, where appropriate, like super continuous care. So the patient waking up in the middle of the night, freaking out about the result, not having to wait till the morning, but being able to actually ask, let's keep it simple, ask a chatbot and say, oh, look, the doctor mentioned something, but I'm really worried that what they said was this. Actually, this is what was said at the consultation. The patient's like, well, yeah, does that mean that they think I've got cancer? Instead of having just the recording, they've got a little bit of interpretation. That interaction then feeds back into some smart reflection back to the doctor. So, after you've gone away, Keith, patient X has really been troubled by this particular area. We've given them this information back. Why don't you contact them to just follow up, just to have that conversation, just to settle them with a bit of human interaction at this point. We could have all sorts of different ways of providing care beyond, like just digitizing what we do right now is some tiny corner of the probability space of what we can do. That there is more light in that space is awesome. But let's also use that to explore other ways of doing things.
It's so interesting that you're basically talking about almost like a new operating system of medicine, because it's so difficult to imagine a new operating system, isn't it? Like, even if you're talking in computer software, it's very difficult to think like, how would I do things on a computer without Windows, not the operating system itself, but like the actual, like, even Mac OS is like window based, isn't it? We have Windows do things. How else would you do things? Like, you think of like MS, when you had MS-DOS, how would you imagine what Windows looked like? And without that, the app interface in iOS, and like, it's strange. It's like trying to think of a different color that doesn't exist. It's like, it's incredibly difficult, almost impossible. Like,
until it's there.
Until it's there. Yeah. And I think you're right. Like, what you're talking about is like a two-way dialogue to think like, how would we reimagine this world? But then that always introduces the question for me, which is like, in that case, what are we aiming for? In that case, what is perfect healthcare? In that case, what is it that we actually want? And it's funny because like, this is the research that I've done recently, looking at like trying to explore like, with all these things where anything is possible, what is it that we want from healthcare? And, I mentioned this on the Pigeon podcast, which I know you listened to, you talked about offline a little bit, but like, this is where all of that empathy research came. I think I mentioned it on the last episode of this, like looking at like what actually denotes great patient experience, because that's surely, of course, we're aiming for perfect diagnosis, perfect treatment, perfect patient experience broadly. If we're going to talk about perfect healthcare, of course, perfect workforce conditions and all the rest of it, and all these other things can come in. But ultimately, if you're looking from the patient side, you'd think, diagnosis, treatment, and broad experience. And it's really interesting that like what people are after, one of the biggest components of patient experience is the feeling of being cared for, empathy. And it's funny that with AI that can do so much, we're in a world where we're talking about AI potentially replacing talking therapies and being the interface to take the history. And it's funny because as clinicians, like, we innately sort of balk at that. And your thinking's gone a little bit further to introduce a different person in the room. But, when I first hear that, I'm like, oh goodness, no, like don't put it there. Like, don't replace all talking therapies with AI. That's not, like, innately, I'm like, that's not what we should do. And I, having done the mini literature review on it and figuring it out, it's because AI cannot display empathy, because empathy is the understanding of emotion, and true understanding is human to human. It's a two-way street. It can display a type of empathy, a synthetic cognitive empathy is what it can do, which means that it pretends to understand your point of view by reflecting it back to you. So it can say, that sucks that you feel that way, and I'm really sorry that's happened to you. That isn't great. I'm sure that you feel blah, 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 because like this has happened, and I understand that must be terrible. It can say those things, but because you know that it doesn't feel that too. The true empathy is a connection of two people feeling a certain way that are reflecting that back to each other over time. And it's funny because like that has now given me a language and a framework to go, like, I now sort of understand like why I don't want AI there, because that's innately what I feel. I feel like a patient needs to respect that another human being is listening, that another human being cares, because I think that's part of the true fabric of what healthcare actually is. And I think if we become okay with saying, well, as a species, as humans, the only thing that's needed when someone feels bad is an AI to pretend that it relates. If we just suddenly become okay with that, that's the new standard of what we're okay with as human beings.
That's the new standard that everyone will get, yeah.
That's eroded a huge part of what I think just human-to-human interaction is, let alone healthcare. But like that becomes our new standard, yeah. So, and what does that mean? Well, okay, we've saved our time because you don't put a human there. And then you just saved our time to do what? what is
I come
living
back to that.
and caring for each other? And is that not what being a human being is? Community and care and the feeling of purpose and togetherness and all those things. Because if we just become okay with AI being the interface of human to human care, which is what healthcare is, I worry that the fabric is completely eroded. And so actually one of the papers that I read literally just says it in black and white. Empathic AI is either impossible or unethical for all of those different reasons. And that's the conclusion that they make. But yeah, that's the sort of journey that I've been on as to like where it fits.
It was really interesting listening to your podcast and the journey. And I hope to be able to go to the event to hear your talk on this. And there's a few sort of points in there as well. The first thing that I thought about, we were talking about fake empathy versus real empathy, as in, person saying, appearing to be empathic and actually just faking it. And does that matter or not? And, the line I always use is about customer service in the US. I'm just back from the US and they're always generally very lovely. And I'm like, I'm sure they don't really care that much, or maybe they care a little bit. And sometimes as a Brit, you're like, oh, it feels very fake. And I was like, yeah, but I still like it. I still like to have this care, whether it's real or not. And then the next thing I thought about was, well, I know you have a dog. I've got a dog. He was asleep in the corner. I don't know where he's gone. He's behind me now. Does a dog have empathy? I'd say yes, I think it does. Yeah. What about a cat? I've owned cats, and I think cat owners are maybe a bit on the fence about this, about whether they do or not. Yet people still have cats and gain a great deal of sort of pleasure from having a cat, and the semblance of empathy and feeling that you get from something that turns up and presents you with a dead mouse. I had a cat in the past. I don't hate cats. And there's all of these things going on. Empathy, like the simulation of empathy that you might get from a machine, I think over time, we as humans will come to some sort of understanding of what empathy from a machine is there for and not there for. You just have to look at the reports of people with AI girlfriends and boyfriends online, having relationships with machines, that they're definitely deriving something from this as well. And then the other thing to say about empathy is actually there are some elements of healthcare that actually I don't I want care, but I'm not necessarily looking for a deep emotional bond, embarrassing problems and so on too. So I'm absolutely agreeing with you that we need human to human contact and communication. Where the technology helps, if it frees up time, it should be freeing up time to allow us to really dive into that. But I think the sort of synthetic empathy we get actually does have a role to play. If you have an option of collecting a sort of automated history through a chatbot, one that is polite versus one that's just, nuts and bolts, I possibly want to have the polite one in there as well. So I don't know if I'd say it was unethical. I think it'd be unethical to pass it off as like this machine has real feelings, and I think that would be unethical. But this machine has a simulation of feelings in the same way that people get impact from a placebo, even if they're told that it's a placebo. There's maybe some impact from empathy, even if they're told that it's synthetic empathy. And there's a correlate to this, which is about people developing AI for loneliness, companionship.
Interesting.
One of the AI APPGs, there was a company called Ditto that's creating AI companions to help combat loneliness, particularly in the older population. And there was some strong pushback from people saying, this is terrible. We should be, what world are we living in when machines have to give companionship to the older population? And the answer is simple as like, well, we're very happy to tolerate it right now. Like, what are we doing about it? Nothing at all. We're happy for, we're happy for third sector to create, tea and coffee mornings. But other than that, we're also very happy to have people only have 15 minutes of contact a day to get them out of bed or put them back to bed. We're happy to tolerate a world where people are forced to be lonely and at the same time happy to stop a synthetic form of loneliness alleviation to come into place. So I'm a wee bit more assertive on the use of the positive use of empathic machines, but at the same time, it is no replacement for a human. It's just that we don't have enough humans to do the things that we need.
Yeah.
Really.
And I'm, learning new information and changing my mind in real time here. But like, there are certain caveats to what I've just said there as well, because that research is done pre-large language models, and just like the thermometer, that when people said that it reduces this stuff to just a number, it then enabled this whole new research into a sector of, metrics, and we can actually standardize certain things. We can reduce things to numbers. We can also still display art in the interpretation of those numbers. And actually then it starts this whole new discipline down there. And I wonder if this becomes a thing here. If we're going to become okay with where we put AI, we should talk about these things. We should talk about, what is the merit of synthetic cognitive empathy versus true emotional human empathy? And where are we okay with it? In the same way with telemedicine, where are we at? Not, I'm going to boo you off the stage at the Royal Society of Medicine for even suggesting, and I'm going to refer you to the GMC. It's like, no, hold on a minute. Can we just, where should we use it? Where should we put this? And actually, I'm going to use those two examples in my talk, actually, because that is...
Oh, well, you're absolutely welcome to. Yeah,
that is wonderful. Well, final thing, just before I let you kick in, is Woebot as well. Because you and I were both fully aware that that was synthetic cognitive empathy. And so the deal that we had with Woebot was that I know you're synthetic. And actually, there was an element there where I think I was more honest with Woebot because I knew it was synthetic empathy rather than true empathy and a human being on the other side. I'm not convinced that I would have got the same. Maybe it would have been better, maybe it would have. Definitely wouldn't have been the same, but I know for a fact that Woebot solved my problem, actually. But what I will say is that I did not have depression, anxiety. I was optimizing my mental health. I was sort of being propped up to normal, to reduce it to a phrase. But that's where I was with it. And it was teaching me about catastrophization. And it was teaching me about tools and techniques that I can use in those moments and all these things that allowed me to go from where I was back up to normal, which wasn't too far away. But the deal that I had with it was that I know what you are. And therefore, I'm going to engage with you on that basis. I think you're right in what you said before, that where that interaction becomes dishonest, where we are passing off. I'll give you a perfect example. When chatbots first got adopted by banks as a way of interfacing with the banks, there was a period where I wasn't sure whether I was dealing with a human or a robot. I was saying please and thank you to this robot. And then by the end of it, where I now know it's a robot because it says to me, oh, you're going to need to speak to a human or a person, I then feel robbed and I feel like I've lost something because I'm like, hold on a minute, I've just been deceived and I've been saying please and thank you. Now I'm a little bit embarrassed of myself that I've been saying these things to a robot. But then I even say please and thank you to ChatGPT because it's slightly nice to me and it makes a different interaction. But the point is that was dishonest initially. And I think that was the problem. And I think that's where this empathy AI research was done in the sense of like, it's okay if you're honest about and upfront about where it is, but please do not pass off an AI as human because you're going to get empathy in one direction from the patient to the AI, and that is not an okay place to be. That is what is unethical from what I believe of the paper.
I agree. Transparency is critical here as well. That upfront about this. I remember when we were at Babylon, and it was the kind of the personality of the chatbot on one of the products, Healthcheck, not the Symptom Checker, but Healthcheck. And at some points, it was a little bit more kind of chummy. It would use emojis and things like that. And we started to move away from it. Now, at all points, it was clear that this was not a human, but there was something about the artifice of using this sort of language that felt that it eroded that a little bit. I think using please and thank you with large language models, interestingly, there is some research that large language models aligned in a certain way will perform better if you use polite language than if you don't. Oddly.
That's fascinating.
Yeah, but then in other cultures and different languages where the niceties of language that we would maybe use in the UK are less commonly used, there would be a cost to using it. It would have worse answers on that as well. So that's just a nice wee aside. I think Woebot, yeah, I used Woebot when I was depressed and anxious, and at that point it wasn't prescribed. I was just sort of around on the internet and used it, and I got some benefits from it. I was doing CBT, and there was a little bit of the sort of knowledge imparting that was quite good. But the thing that Woebot did better than anything else, humans included, was that when Woebot said it would get in touch, it was always on time. Like it says, I will be in touch with you tomorrow morning at 9 a.m. 9 a.m., Woebot. Hello, it's Woebot. I said I was going to be in touch with you. Here I am. How are you doing? And you know what? That meant a lot to me at the time. And I knew it was a machine and everything like that.
Yeah.
But like, just there's something about the kind of timetabling in that situation that things are happening that was important to me. So there's a lot of interesting stuff in there. And I'd be interested to know when that paper was written, because I think the empathy that is expressed in a large language model feels qualitatively different to the sort of rule-based, like, I'm sorry you feel that way. There's kind of more to it.
Yeah, I'll try and find it. And send it over to you. I don't think it was recent. I don't think it was in the last 12, 18 months. I think it was older than that. What's your vision for the next 12 months? I'm interested. Like, where do you think all this goes in the next 12 months? 12 months is a long time, actually, in this world. I mean, geez, like the whole thing's only been around probably 12 months. So what's your vision for healthcare in the next 12 months with large language models? And for people that are listening that are either interested in it or open to it or really love it and want to become a part of bringing these things to the fore, like, are there communities of people that are talking about this? Are there things that people can get involved with? And how do you go about, I guess, being involved in those communities and kind of keeping your knowledge up and all the rest of it, and crowbarring this stuff into healthcare, or indeed getting it welcomed with open arms? Like, what does your next 12 months look like in this world?
So I think sort of generally, if I just talk first of all about where I think generative AI is going in the next 12 months, I think we're hitting another kind of period of acceleration, even though things are probably still, well,
that's
in relative terms. And the reason I say that, I know it's like, it's already too much. But it does sort of do this because OpenAI's GPT-4 was kind of king of the hill, a large language model that was performing best out of all the models. Yet in the last few weeks, we've had the launch of some new models from different providers that are the same or even better. So Anthropic is a company that brought out Claude 3. Mistral is an open source company that brought out a latest version of Mixtral, which is free to use, and that performs better than some models of GPT-4. Meta are about to release Llama 3. Google have got their Gemini Pro. There's a lot of exciting new products coming out with GPT-4. Now, what that means is that OpenAI, who have, as is rumored, got GPT-5 trained and ready to go, are very likely to have that out in the next little while. So the next version of GPT-5, which, of course, they would say this, Sam Altman and everyone else says that it's going to be meaningfully better than before. What that means, I don't quite know, but I think that we're going to see the competitive environment for these models improve. So the sort of state of the art of large language models is going to move forward. And what that means is that people are going to be able to practically do some of the things that we're talking about that right now are more thought experiments. So I think that's the kind of cutting edge. Alongside that, we're going to see some of the new AI-powered hardware and gadgets coming out. And that's things like the Rabbit R1, which is, I've ordered these, are hopefully arriving soon. These are like smartphone-like devices that will interact with systems for you. So we're going to start seeing large language models become large action models. And what that means is that instead of going into a different app to do something, you'll use a model and it will use the apps for you. And I think that we're talking about user interfaces before. I think the next generation of user interfaces, like what comes after Windows or Mac OS, what comes after apps, something like this might do, where you interface with one thing and it handles everything else for you. That would be great inside medicine. Like instead of having to navigate these EHRs that are sometimes difficult to navigate, I'd be able to use natural language and it would do the stuff for me. I think we're going to start maybe seeing some of that happening. Certainly Tortoise books on that.
I'm just imagining like going back to basically like an MS-DOS interface now. It's just literally like just a black screen, like a nice little white ticker, like little cursor ticker thing, and like all of a sudden just ask it a question, it answers. It's like playing one of those old school games, isn't it? Where you like had to make the choices of like saying whether to go left or right.
Zork, or something like that. These text adventures, or whatever it is. I think what will be nice will be we'll be able to have the interface that we want. So I think those are coming up. I think within healthcare we're going to see the maturity, like a maturity of some of the products, such as Tortoise. There are other ones out there, of course, but coming into the real workplace, maybe some of the papers coming out of how they're being implemented as well. So we'll see it being used a little bit more often. The regulatory position, I mean, this is one that'd be interesting to see what Hugh thought about the coming 12 months. But the truth of it all is that no one's got a large language model in a medical device yet that I'm aware of. But I know that people are working very hard on that. And there'll be an element of a sort of dam bursting if that gets pushed through. You know, if someone manages it, then I think there'll be a big rush. Otherwise, everyone's going to still be pushing on the other side of things. So like anything, it's going to be accelerating faster in the state-of-the-art sector versus the real-world implementation. But there'll be more experience of real-world implementation and more experience of people having, exposed to large language models in their non-healthcare life, thinking, why on earth is this not being used in healthcare? And of course, standard AI, imaging and machine learning is going to be making progress too. So I think it's incremental implementation over the next 12 months, but some fairly substantial changes in the state-of-the-art technology. How do I stay abreast of this? It's the usual thing. You go on LinkedIn, you follow the right people. You go on social media. I came off Twitter because I just don't like the mess that Musk made of it, but I'm on Threads instead. And as a result of that, I follow some people and they tend to tell you the news, and then I dig into it. And I have a kind of pipeline where if I see a paper or interesting news on LinkedIn or social media, I kind of send it onto my Remarkable tablet. I've got a big ebook reader, and that way I read it and process it. So I've got a little pipeline to keep me abreast of this. And then it's a matter of interacting with people on social media, going to AI events, some of the health tech events, and speaking to folk. That does that. I'm not aware of any specific kind of health AI ones. The Turing Institute has a
start one at this point, Keith. Like honestly, surely you start one.
Yeah, well, but then yes, but at the same time, I've also got to run this business and another business, and everything too. I definitely think getting a group of people together, and then and also I stay in contact with people that really know their onions, like Harris Schwabe and Annabelle Painter, and people doing really cool stuff and interesting stuff in that space. And then turn up on panel discussions. That's how you stay ahead of it. And then the final way that you stay ahead of it is you actually use it. I use large language models extensively in Curistica in my own consultancy to help with the work that I do every day. I use it with my clients. We're very open about how we use this. We have guidelines on how to operate to this. We've taken legal guidance on this from folk. So all of these things allow me to sort of immerse myself in it. But ultimately, talking about it is one thing. You got to do it. And I give talks on generative AI and prompt engineering because I learn by doing. So let me help other people understand enough so they can start doing, and then they'll learn. And I think that's the way to do. Because if anyone out there's used ChatGPT and think, oh, it's okay, it did this, but I wasn't that impressed. I promise you're not using it the right way.
Yeah.
You're just sort of asking it once and then bouncing off it. Deep conversations, using certain conversational structures. What ChatGPT is doing is you're asking it a question, and it's a little bit like asking you. So if I ask a question like, explain large language models to a layperson, and ChatGPT will create a document. It's a little bit like me going to you and saying, right, I want you to do the same thing. Oh, by the way, when you type it, you're not allowed at any point to press delete or revise anything. You just have to do it in a single stream. You don't have to settle for that. Once it's done it, you can say, can you look at this again? Can you change it? And most people don't go that next level. I think once you start doing that, you then start to get really interested in what it could do. When it plays roles and you have multiple agents talking to each other, I think those are the things that get very exciting. And all you need to do to get to learn about it is learn some of the basics, feel comfortable to use these things safely, and then you're off to the races.
Love it. Keith, it's been an absolute pleasure having you on, mate. I'll tell you what, since I've said it, I can't get these like text adventures out of my mind, because ChatGPT can just create infinite text adventures with a little image from Dolly.
Yes.
You could just create a load of custom GPTs with different universes, with different things possible, and whatever you say to do in real time will affect the adventure in a completely new way. Put that into a front end of an app, and all of a sudden you've got a nice kids' bedtime stories
nice wee game. Yeah.
app, or a nice little game for whoever. Yeah. Wow.
Yeah.
If anyone listening wants to put that together and just tag me in it, that'll be great. That'd be lovely.
Well, remember, actually, you can go from that, but also it's done in medical education. You just say the same thing. You are a patient with this thing. You've come in to see me. Pretend to be allows people to exercise it. So you can be adventuring in the realms of Middle Earth, or quizzing patients or testing it. Like, honestly, because almost anything is possible, it's difficult to wrap your head around it. But learning how to get started and then digging into things that interest you, that's the way in.
Yeah. And we started here, so I will finish here. What was your favorite game on the Atari?
Oh, I can answer this brilliantly. I was just in America, right? And as part of this little trip that I did, I went to Philadelphia. And late one night, I went to a pizza restaurant in Philadelphia. And it was a kind of retro place. And they had an Atari 2600 and a CRT TV on the side. I've got a photo of it. And I played Yar's Revenge for the first time in nearly 40 years. I played Yar's Revenge, and I managed to get to level 3. I remembered how to do it all. I got there, and so I can eat that. That's a straight, you may think you've got me there, but I played Yar's Revenge within the last week.
Incredible.
On original hardware. So there you go.
Keith, it's been a pleasure. Thank you so much, mate.